basic series of Asami India, basic series of Ilizarov, and today we are having Tamilnadu and Pondicherry, and Dr. Subramanya Gandhi will be coordinating the webinar. So I request our President, Rajat, to speak a few words.
Hello everyone, and I'm Dr. Rajat Agrawal, President Asami India, and welcome to this second session of Asami India regarding the basics of Ilizarov and limb construction. And every year we have a state organizing this webinar series, and this time this is being organized by the Tamil Nadu and the Pondicherry state, and we have our dynamic Dr. Subramanya Gandhi, state representative of Tamil Nadu. He is organizing that. And today we are very lucky, actually, our international level honorary speaker, Dr. Govardhan, he has agreed to present his talk on osteotomy rules and types. And we are very grateful, sir, to be here. And we welcome you, sir. And it will be we are sure it will be a great learning experience. And other than that, Dr. Subramaniam will be talking on the biomechanics of Ilizarov. And we have Dr. Suresh Gandhi Boopalan and Dr. Manoharan and Dr. Velmurugesan. They will be presenting the cases regarding the deformity and the lip reconstruction. So I welcome you all, sir, and let's start this webinar. So I hand over to Subramaniam to coordinate the webinar. Subramaniam, please.
Yes. So good evening, everyone, for giving Tamil Nadu Association an opportunity to present today. So very proud to have Professor Govardhan sir as our speaker for today on the guest lecture. And we have three eminent speakers from Dr. Suresh Gandhi sir from JIPMER. He is the head of the department. Dr. Velmurugesan sir is an associate consultant at Ganga Hospital, renowned internationally. And Dr. Manoharan, he is from Vellore, Naruvi hospitals. And moving on for today's presentation, the first presentation will be by Professor Govardhan sir. A small introduction to him, though it is not required. So some of his achievements will be sharing today. So Professor, he is Emeritus Professor of Orthopaedic Surgery of MGR Memorial Hospital. He is the founder director of Vasanthi Hospital, Chennai. His area of interest is limb reconstruction, joint replacement, pelviacebular fractures, and pediatric orthopedics. He has been awarded the best teacher by Tamil Nadu MGR University. He has been awarded the Master of Orthopedic Surgery Award by the Governor of Tamil Nadu. He has achieved the Lifetime Achievement Award from Tamil Nadu Orthopedic Association and Lions International. He has given numerous national and international presentations all over the world. He has been the Secretary and President of Tamil Nadu Orthopedic Association. He was the Secretary of Indian Orthopedic Association from 2006 to 2008. To his credit, he started the first cadaveric lab in Rajiv Gandhi Government Hospital in the year 2011. And he has been the former director of Institute of Orthopedics, Rajiv Gandhi General Hospital, and Madras Medical College. So we welcome you, sir.
Thank you.
Thank you for accepting our invite.
Thank you, Subramaniam. Thank you very much. I thank the Asami India for giving an honor of presenting my work today. And we are just prior to the Vinaya Chaturthi, so I'll be brief so that we can close the meeting at the earliest possible time. Shall I share the screen?
Yes, sir. Please, sir. You can proceed, sir.
Now, basically,
I request all other speakers to mute.
The word osteotomy means surgical sectioning of the bone to correct any deformities or to achieve whatever we want within osteotomy. There are various types of osteotomies which are there in the O, and we are going to go with the osteotomy rules and the types of osteotomy. Prior to that, we should know where exactly the osteotomy should be done, and the deformities may come in various forms. Now, this is a girl, very simple. You can see that the patient has got a bilateral genu valgum. This is one gentleman who has got, looks like a procurvatum deformity of the tibia. This is a O deformity of the lower limb on both sides. Here is a lady who presents as if she has got a flexion deformity of the hip and flexion deformity of the knee with a shortening of the lower limb. This boy walked into the children's hospital like this. He was as if sitting in an armchair and walking into the OPD. That is his frontal view. One more chap who is 14 years old boy who has got a O deformity. And most of the time, the classical teaching is when you bend the knee, if it disappears, it is the problem is with the femur. Now, this is one more deformity where there is a windswept deformity. On the right side, you have got a genu valgum. Left side, you have got the genu varum. He is a 35 years old railway employee who had a painful knee on the left side. This is a child which I have shown you earlier. Now, these are the types of deformities which you will see in a government hospital, in a government setup. These were the persons who have come to children's hospital for treatment. Where do you think that the deformity is? For that, you have to put the child on the couch and keep both the lower limbs in the neutral position with the patella facing forwards. Now you will realize that he has got a gross genu valgum. And that's how he stands if you make to stand with the genu valgum, which is shown. With these type of deformities, unless otherwise you know where exactly the apex of the deformity, you cannot put your knife and put an osteotomy to correct the deformity. So this is the X-ray of the same chap who has got something like a serpentine femur on both sides, which has got gross deformities. He has also got other problems like laterally dislocated patella and rotational component, oblique plate deformity in the lower. One more example of a gentleman who underwent lengthening of the tibia. After the lengthening, he has got this procuratum deformity, and it appears as if that he has got a double level of the knee joint. You can see the X-ray. That's a gross procuratum with subluxation anteriorly of the knee joint. This is the when you bend the knee, it gets nicely relocated. One more example of a boy who presented with post-traumatic deformity of the right lower limb. You can see that he has got a bilateral varus deformity, but on the right side, he has got a cicatrix in the front of the thigh, which is binding the quadriceps. He doesn't have much movement in the knee. And on this video, you can see that in the frontal view that he has got a gross varus deformity. But when you put the patient on the table and if you see the range of movement, you will be astonished to see that he has got a hyperextension at the level of the knee and his flexion is only this much. What is the reason why he has got this deformity? His deformity was very much revealed by a true lateral view where there was a recurvatum deformity of the femur. So you have to assess these deformity clinically very well and find out possible causes for etiological causes, assess what is the bony deformity, what is the soft tissue component, and we have to find out the local condition, whether it is conducive to do any corrective osteotomies, and also see whether any associated soft tissue contractures. Whenever you want to correct a deformity, the limb can be assessed with an X-ray, where the proximal one, we can use an axial line of the proximal segment and distal segment. If they meet at the apex of the deformity, you can do a correction of the deformity at the apex of the deformity. You can make an osteotomy. Either you can choose an open wedge or you can choose a closed wedge, depending upon what you want. In a closed wedge, you will get shortening of the limb. In an open wedge, you are leaving a big bone void, but you will get lengthening at the same time. So you may require, in a situation, a bone formation at the local site. But how to correct this deformity? Where will you place your osteotomy? To assess this, we should have some methodology. This boy was operated by one of my colleagues in Tamil Nadu, and he did a closing wedge osteotomy on the medial side. So a genu valgum become a genu varum with a hockey stick deformity or gold stick deformity. So this is what has happened. He has got a genu valgum, which has become a genu varum with medial translation of the distal femur. One more example of a boy who was treated in Madurai with bilateral genu valgum. He was also treated the medial closing wedge osteotomy, where they have created another deformity with translation of the distal fragment. So that is how he presented in Government General Hospital. So how to correct these deformity, analyze these deformity in a methodical way and do a good preoperative planning. And the preoperative planning is a long leg x-rays, apply a malalignment test, localize the apex of the deformity. And if you read this book, which is the Bible for us for deformity correction, you will be able to get. Most of us know how to take a long leg x-ray, which is to be taken from the hip to ankle to assess the deformity with the patella facing forwards. If you don't have the facility, you can take 2 segments of the femur, but the raise should be at the same level. The distance between the femur and the tibia to the X-ray tube must be maintained so that you will get a normal X-ray. And whenever you are taking an X-ray, you see that the patella is facing forwards. This is how you will analyze. Femoral reference lines are given. The proximal pharyngeal, lateral proximal femoral angle, which is about 90 degrees. And on the lower side, we have got the lateral distal femoral angle, which is about 87 with a margin from 85 to 90 degrees. Tibial references are shown here. Subramaniam, you can always stop whenever you think that I am exceeding time. Okay.
Sure, sir. Sure, sir. Please, you can
So
go on.
this is the normal mechanical axial alignment, where if you draw a line from the center of the hip to the center of the knee to center of the ankle, and these are the standard values which one should be in their memory. This is the mechanical axial alignment. This is the anatomical axial alignment. You can choose any one of them for correcting this. And when you use the malalignment test, you can see the collinearity of the hip, knee, ankle. You may have a problem in the femur or the tibia, or there may be joint laxity, condylar deficiencies. I'm just run through this. This is okay. Now, this is an example of a varus deformity. Here, the mechanical axis line is on the medial side. So you draw first line between the center of the head, the center of the hip to the center of the knee, and assess the distal femoral angle, lateral distal femoral angle, which is about 87 degrees. But medial proximal tibial angle is 72 degrees. So you draw the line, proximal segment of the tibia, you can extend it. And from the distal portion of the ankle, you draw a 90-degree vertical to form the lateral distal tibial angle. They meet at the apex of the deformity. And once the apex of the deformity, that is the center of rotation of the axis. You have to draw a bisector line to this, and along the bisector line, either in the convex side or on the concave side, you can place your hinge and you can correct the deformity. So determine the magnitude, level, site of the deformity done by plotting the mechanical axial line passing through the center of the head of the femur and the ankle. Now come back to the original thing which was there in shown to you, and that was the deformity. So deformity was corrected because we have the hinge there, and the deformity correction is by means of an angulation correction and translation, so that it has become a neutral angle. This is an example of a patient who had an injury to the tibia. He had an ACL tear which was repaired. He had the painful ankle because of the valgus deformity what he had. So we analyzed his deformity, and we passed the mechanical axis line of the femur, which showed that the lateral distal femoral angle was normal. Medial tibial angle was also normal. So we draw a line from the distal tibia and lateral distal tibial angle was, these two lines met away from the tibial line. So the apex of the deformity is not within the bone, but it is away from the bone, which means that there are two apices of deformity, which can be very easily delineated by a central line like this, which is an axial line. Now we have got one cora at the above level and another cora at the distal level. Okay, so this patient had removal of the implant, double level. This is one level of the cora, this is another level of the cora, and I have done osteotomies to correct it. This is one cora, this is another cora, and you can see that the entire limb has become straight. So if you analyze and where the apex of the deformity, you will get a good straight line for these patients. So now we'll frame an osteotomy role. If the osteotomy and the angulation correction passes through the same cora, the bone ends will angulate relative to each other without any displacement. Okay. So the osteotomy should pass through the bisector line. Opening wedge osteotomy if the hinge is placed on the convex side, and closing wedge osteotomy if the hinge is on the concave side. The picture shows this, and that is the cora, center cora, and the bisector line. And in the bisector line, you can place a hinge on the convex side or concave side. In the convex side, if you put it, you will get an opening wedge where you will get a bone formation. If you use a hinge at the concave side, then you have to resect these alpha amount of the bone to get the correction of the deformity. Pictorial diagram where the cora is defined on the bisector line. This is the hinge which has been applied. We have got double level fixation above and below, and an opening wedge has been done. If you keep the hinge away from the bisector line, away from the bone, then you will get correction of the deformity and a lengthening. This is the example of a closing wedge osteotomy where we remove the part of the bone on the convex side and close the wedge. This is how we distract and get the opening wedge. Example of a boy who had an osteomyelitis distal femur with a varus deformity, which has been corrected. You can see the cicatrix which has formed because of the osteomyelitis. These are all my old patients when I was working in GH, they have come. This is a chap who had a post-traumatic injury of the ankle. You can see the cicatrix on the medial side. He had a varus deformity. His deformity was analyzed and we found that it is in the metaphyseal region. So we had the fixation above and below and got an open wedge type of an correction of the deformity. He also needed lengthening, so a proximal lengthening was done, not relying on a lengthening at the lower level. Whenever you have got an angular deformity very close to the ankle, it may have a compensatory effect on the subtalar joint. So usually we use a frame lower down so that once the deformity is corrected, you can find the deformity of the subtalar joint, which can easily be corrected. So you see the pre-op, there is correction of the deformity of the ankle. Then you find the valgus deformity of the subtalar joint, which has also been corrected. Incidentally, the boy had a cavus deformity, which was also corrected in this case. There's one more example of a person who had a post-traumatic injury to the post-traumatic deformity in the knee joint, where you see that there is, instead of the posterior slope of the tibia, you have got an anterior slope of the tibia. And you can find out the apex of the deformity is at this level. Usually you draw a line from the anterior to posterior of the slope. For 1/5 of the anterior 1/5 is the line where the axial line will intersect. So the red line is the normal intersection line, and the white line is the axis of the distal fragment. After the removal, we have put the frame, and basically I am showing this to show that once you have got the hinge at the proper level, you will get a nice opening wedge osteotomy. You can see that open wedge anteriorly, and you have got the correction of the deformity, and you have got the axis which is intersecting in the anterior 1/5 of the articular surface. He had varus deformity also, which was also corrected with hinges adjusted. We also lengthened him, and that is his deformity correction. On the left-hand side, you have the corrected limb. On the right-hand side, which was the pre-operative. That is his limb motion. He has got a good flexion, and both the limbs are equal. I'll skip this. Now, we'll go to the other example, where it's a Blount's disease of a boy who has got bilateral. And if you draw the mechanical axis line, the femur and mechanical axis line of the tibia, they intersect very close to the epiphyseal plate. So to correct the deformity, you put the hinge at the level of the apex of the deformity, have the ring above and below, and once you try to correct it, you will find that the deformity is corrected, not with the only angulation, but the distal fragment is translated. So there are two things which are happening. One is angulation correction and the translation of the distal fragment. Pre-op and post-op is shown. Coming back to the one of the example which I showed you earlier, bilateral genu valgum, and this girl, that is the centers, and this is valgus deformity. And you can find that the lateral distal femoral angle was 76 degree, and lateral distal tibial angle is 89 degree, and her deformity is mainly because of the at the level of the distal femur. So if your intersecting lines are very close to the epiphysis or physeal plate, then you have to do an osteotomy at a higher level. So this is the example. The apex of the deformity is there, but you cannot do an osteotomy at that level for various reasons, like growth plate is very close to that metaphyseal or juxtaphyseal deformities, which are, we cannot do an osteotomy very close to the growth plate. So we avoid that and do an osteotomy at a distal. When you do that, you get a correction with angulation and translation of the distal fragment. That is what the osteotomy rule 2. If angulation correction axis passes through a cora, but the osteotomy does not pass through this point, the bone ends at the osteotomy level will both angulate and translate each other. This is the pictorial diagram, and you can see that the distal fragment is angulated and translated, and the end result is that her lower limb has become straight. That is the long leg X-ray. That is a function of the limb, and you can see that both sides has been corrected, and you can see the straight limb. Now, this is the extension of the same thing, which whenever you have got a growth plate, deformity is very close to the growth plate, you cannot do an osteotomy. If you do an osteotomy very close to that, you will be all right with the correction of the degree of the deformity at that level. But if you do an osteotomy which is lower than the apex of the deformity and put a hinge which is not at the apex of the deformity but at a lower level, when you do the correction, you will still get a lower limb will be equal, but there will be translation of the distal fragment. So if you want to correct further and make the center of the knee and center of the ankle collinear, then you will find that the medial proximal tibial angle has become 84 degree and lateral distal tibial angle. That means the ankle has become valgoid. So whenever you are doing that, this is the same thing. Instead of 37 degree, you are trying to correct it so that it will fall back into the mechanical axis line. you will find that the MPTA will change and LDTA also will change. So you need to do a translation so that you will get a good correction, which is the hallmark of the osteotomy rule 2. If you are using a dome, from the apex you have to draw rather than a center which is lower down and do a circle, which is a good example is a McVay osteotomy, where the apex of the deformity is closer to the articular surface, but McVay has done the dome in a reverse fashion. So there was a translation at the level 7. Hinge must be placed at the apex of the deformity and not at the level of the osteotomy. Correction of the osteotomy is achieved both angulation and translation. Osteotomy consideration, I do a lot of dome osteotomies and also do corticotomy and gradual distraction. Dome osteotomy is technically demanding, causes no limbal discrepancy. You can get an acute correction of the deformity and it is possible to compress it. Avoid all discomforts of the distraction for the patient. This is an example. You have to plant the center of cora and then put a pin there, and with the help of the stacked rancho cubes, you will be able to draw a dome, which is shown in the diagram. Some examples of the domes are shown here and deformity corrections, right? These are all my old patients whom I have done in 1992. Now, the same principle can be adopted for if you are doing multiple level in a chap like this who had deformity in the distal femur and proximal tibia, and he didn't want any of the Ilizarov. So we followed the principles of the deformity correction, but instead of using the Ilizarov frame, we have used internal fixation. This is how a dome is created. Initially, we had the shank pin parallel to the joint line, one perpendicular to the shaft, did the dome, and once the dome is marked, you do an osteotome, which is connect. Then you use an osteotome, and with the help of a plier, you will be able to translate the distal fragment. Once you have got the correction, it has been fixed with a distal femur nail. Pre and post-op X-rays are shown in this patient. I'm coming to the last factor where a multi-apical deformity, if they are there, then you will get not only one apex, but there'll be two apices together, in which case you have to do bisector lines and both coras and do the deformity correction as shown in step 4A, 4AB, so that you will get a straight line. But if you've got a zigzag pattern like this, instead of doing a resolution like this, you can also correct with an osteotomy at a lower level. Ignoring this, if you have got a joint line above and joint line below, they are all parallel to each other. This is the osteotomy rule 3. I thank you for your kind attention.
Thank you, sir. Thank you so much, sir. I think you have covered the A to Z of deformity correction, covering from all the basic cases to the highest level of cases. A wide variety of case examples we are able to showcase, sir. Thank you for explanatory talk, sir.
Thank you. Thank you.
Dr.
I
Govardhan,
welcome
you have
Manish Dhawan, sir,
presented.
and Arya Agrawal, sir.
Dr. Govardhan, good evening.
Good evening, sir. How are you, sir?
I'm fine. See, today you have almost covered whole of deformity correction.
Thank you.
So basic principles, I think it's a good revision, and type of work and cases are very good. And a person, a expert like you, we always cherish that you should come to Asami meetings more often and share your experience. I
Yes.
have no question to ask Professor Govardhan. He is like much above in deformity, this thing. But it was a eye-opening that how you can manage if you know the correct principles and you know the angles, and you can, learn from the master that you can tackle any type of cases. So I really congratulate you on your presentation, and keep coming to Asami regularly. And
Sure.
I now hand over to Professor Agrawal, who will grill you now.
Yeah. Dr.
Good evening, sir.
Govardhan, Dr. Govardhan, good evening too, and very nice presentation. But my one question is, in all the cases of the supracondylar osteotomy and the upper intertibia osteotomy, do you have the stiffness of the joint problem?
No, sir. Most of the time, we will be using an internal fixation after the dome osteotomy. So we mobilize these joints very well. And only problem with supracondylar osteotomy is
Yeah.
you must get adequate amount of the distal fragment. If you don't get adequate amount of distal fragment, if you are using an interlocking nail, you will not be able to get a purchase on the distal fragment. Now, I think the distal femoral nails have got angular interlocking slots also, which are available. I think even the nebula people have got not only 2 screws, but there are about at least 5 screws you can put. Those type of nails, if you use it, you can start mobilizing them at the very, very early stage.
Thank you very much.
Thank you, sir. Thank you, sir.
Now, I'm talking about the Ilizarov when you do the supracondylar osteotomy, any osteotomy above the knee.
Yes, sir.
You don't have 2/3 of the ring. Most of them circular rings. So do you have any problem of the flexion of the problem of the knee?
No, if you are using a full ring instead of the 5/8 ring, in 5/8 ring, you will be able to bend the knee beyond 90 degree. Whereas when we are using a full ring, the advantage is the wires can be passed at an angular level so that we will get at least almost 90 degree to each other, the wires, and pins will be there. So while passing the wires, as you will be knowing, you will be bending the knee so that you will extension and bending depending upon where the wire is passing. Maintain a good amount of flexion post-operatively, at least up to 90 degree in these patients with physiotherapist help. I think that is the key for the success of getting a good functional knee.
Actually,
Sir,
when
one
we
question,
apply
sir.
the frame, we put the flexion up to the 90 degree.
Yes, sir.
So that any screw anywhere in the quadriceps is there, that hampers the flexion deformity. So when we apply the femur frame, we always see that our flexion is up to 90 degree.
Yes, sir. Yes, sir.
Sir, can I
Thank you
ask
very
one
much.
question, sir?
Yeah.
Yes,
Sir,
sir. I
what
have
will be the order of correction of your deformity, sir? If there is a rotational deformity, angulation, translation deformity with lengthening problem for a single patient. So how do you address first what all deformities, in which order do you correct it, sir?
Angulation translation first, and then lengthening, rotation at the end. Agarwal sir, आप सहमत है?
Yeah, sure.
Sir, my question is regarding the rotation. Sir. In a
Yeah.
gross deformity in femur, whereas deformity always go along with the internal rotation deformity. When try to correct the varus deformity by gradual method, so how to include the rotation, like bringing the external rotation along with valgus correction? Sir? Yes, I had one bad experience in my one case. So in that case, I was trying to do acute correction, but I was not able to incorporate the internal rotation to external rotation deformity. So,
Now, if you go through the Ilizarov book, there are various frames adjustment with which you can do, and there is a device which can be fixed in the distal fragment and the proximal fragment, which can translate. With that translation, you will be able to achieve a rotation. I don't see such mechanism being now available with Pitker also. But in the earlier days, they used to give us, and those boxes are with me. So when you try to rotate the distal fragment, we connect in 3 places. And from the 3 places, we do the rotation. and gradually you should never do an acute correction. Whenever you do an acute correction of the rotation at the level of the regenerate, you are likely to get a delayed healing of the regenerate. You may have difficulty in consolidation of the regenerate. So never do that. Once your regenerate is there, protect the traction there in the regenerate side, and try to rotate also in the gradual manner. I think in the Ilizarov book, you can very easily see, you can have these male or female side plates are there with which you can do that. Those diagrams are there. I don't have it in this computer, so I'm not able to share with you. Vasudevan has joined with us. Good evening, Vasu.
Yeah, actually, how can I speak that? Actually, this is the basic principles. Whenever there is a varus deformity, there is an internal rotation. And when you go towards the normal or valgus deformity, so it automatically, the mechanical forces reduce the internal rotation, and always there is a valgus, knee valgus, it goes into the external rotation deformity. That is a basic principle there. अरे इसका slide नहीं क्या स्पीकर हट गया क्या?
Sir, any more questions, sir?
Yeah. The basic principle is that wherever there is a varus deformity, it is internal rotation. Whenever there is a valgus deformity, there is a external rotation, because the mechanical forces are working that where you are going to correct the deformity, the mechanical forces from varus to internal rotation to neutral or external rotation. So I've never seen any case having the valgus deformity with internal rotation. The mechanical forces reduce that.
So can we proceed on to the next topic for today, sir?
Yes, please. Yes, please.
Yes,
I think we can proceed.
thank you. So I'll be sharing my screen now. Good evening, everyone. The second topic for today will be on the biomechanics of Ilizarov. And I'm Dr. Subramanya Gandhi. I'm a consultant Ilizarov surgeon from Chennai. So the June 15, 2021 marked the 100th birth year of Professor Ilizarov. This was the stamp which was released by the Russian government honoring Professor Ilizarov. And it marks 70th anniversary of the Ilizarov's method and the 50th anniversary of the Kurgan Ilizarov Center. So the robotic surgery, which is being more common last decade in the medicine field, we orthopedic surgeons can proudly tell it has been introduced around 70 years back. So what is there in robotic surgery is the minimally invasiveness and accuracy, which both can be achieved from our Ilizarov technique. And what is the other uniqueness of the Ilizarov technique compared to other techniques is even in the post-operative period, the fine-tuning and correction can be achieved. So it is a must in every surgeon's armamentarium, which bails you out from very difficult situations. So the principles of Ilizarov can be divided broadly into Ilizarov's biological principles and the biomechanical principles of the Ilizarov fixator, which is to achieve a stable frame. So the biological principles will be the loss of tension stress, which is the process of a new bone formation and soft tissue regeneration following a slow, gradual and controlled distraction. So what are the features are to achieve a minimal disturbance of the bone and soft tissue at the osteotomy site, a delay before distraction, that is during the latency phase, the neovascularization takes place, a controlled rate and rhythm of distraction, performing an atraumatic corticotomy less injury to the corticotomy site, and always use a functional use of the limb and physiotherapy during the course of treatment. So what is optimum stability? So we all should know that stability is not adding more wires and shank spin, which lead on to rigidity. So rigidity is something like an undesirable stability which which makes the construct more stiff, and we will not be following the principles of Ilizarov to have a new vasculogenesis. So desirable stability is we have to perform a controlled and axial micromotion. So what are the forces of undesirable stability? Are angular bending forces, shear forces, and rotational forces. So today we'll be learning the secrets of the Ilizarov fixation. So the factors contributing to the stability are divided into two. One is extrinsic stability, and the other will be the intrinsic stability. The extrinsic stability are the wire and shank spin's diameter, tension along the wire applied over the wire, the crossing angles of the wire and shank spin, use of an olive wire or a drop wire, how many wires or shank spin each fragment you require. And coming on to next, the ring size, diameter, location of the ring, material and design, the number of rings per segment, and the number and position of connecting rods and the span of bone head. So each of this factor leads on contributes to the stability of the construct. So the intrinsic factors for stability will be the area of tissue contact between both the bone ends, the length of gap between the bone ends, the mechanical configuration of the bone ends. That is whether whether it is transverse or any oblique or spiral or interlocking pattern of bone ends, the condition of soft tissue surrounding the viability of soft tissue surrounding the bone ends, and the modulus of elasticity of the tissue between the bone ends. So external stability, that is the frame stability, is always under the surgeon's control. Here you can see a distal femur valgus deformity in a child following a pediatric childhood injury. So here the distal femur is a very small fragment. So just putting a ring only in the distal femur, we will not be able to achieve a good stability. Here we have extended the frame to the proximal tibia also to achieve a good stability of the construct. We have applied a drop wire. You can see here an olive wire which has been used as a drop wire to get additional stability, and the deformity has been corrected. So what is axial micromotion? The tensioned wires resist bending, translation, and torsional forces. It allows axial micromotion to happen, which creates an ideal environment for fracture healing. So that is why the micromotion is very important in Ilizarov to have the fracture healing. So how much is the micromotion to happen? It should be less than 1 millimeter on maximum loading. So now coming on to the wire diameter, the Ilizarov wires are made up of SS316L. So there are two different sizes, that is 1.5 mm and 1.8 mm. The 1.5 mm is used in pediatric and adult forearm fixations. 1.8 is used in adult humerus, femur, and tibia. So now coming on to the tip of the Ilizarov wire, there are two types. There is trocar tip and bayonet tip. So the trocar tip, it is mostly used in the cancellous bone, and the bayonet tip is used in the cortical bone. And the second part of the wire, another factor in the wire will be the olive wires, that is the beads in the Ilizarov wires. So that also plays an important role. We'll be seeing later. So why do you choose a wire of this construct, that is 1.5 mm or 1.8 mm, rather to use a 2 mm or a 2.5 mm diameter wire? Because this is the ideal level at which you get a low stiffness with a sufficient strength to resist the breakage or plastic deformation. Suppose if you use a 2 mm or a 3 mm Ilizarov wire, if you make like that, it is going to make the construct more stiff, where the axial micromotion will not be present. So most important problem we face in the Ilizarov is going to be the pin tract infection. So proper wire passage is going to be a paramount importance. So there will be a mild wobbling of the wire when you drill. So try to use it, hold it with the left hand using a saline gauze. And next, you can see in the image D where the wire is passed through the bone, but it is completely passed through the cortical bone. So what happens when the patient starts to load or do a deformity correction? This wire can break or cut through. So the passage of wire, you should feel through the bone, through the first cortex. Then there will be resistance in the initial cortex, and then there will be a give way in the medullary canal, and again there will be some resistance in the second cortex. So this field should be felt by the operating surgeon. So what will be the ideal tension? What is the safe limit? This is very, very important. So how do you decide how much tension can be given? So the factors to be considered will be what is safe limit, what is yield point, what is break point. The safe limit is 50% of the yield point. So what is by definition yield point? Yield point is at the level at which the Ilizarov wire makes to start to have a plastic deformation. Whereas the safe limit is at the level till which the wire has only an elastic deformation where it can recoil back to the ideal position. After plastic deformation, the wire starts to bend or breakage will be present. So the safe limit will be 50% of the yield point. That is, for a 1.5 mm Ilizarov wire, the yield point is 210 kgs. The safe limit will be 105. And for a 1.8 mm wire, the yield point will be 305 kgs. The safe limit will be 150 kilograms. So these kilograms will be seeing the dynamometric wire tensioner, how to apply it. So what are the factors that lead on to wire tension, loss and loss of wire tension? So as you increase the wire, temperature increases. So if you pass the wire, Ilizarov wire, a single wire for more than 2 attempts, the tip of the wire becomes blunt, and that creates thermal necrosis, which lead on to osteolysis and thereby loosening or infection. Second will be more cyclical loading of the wire, also loses tension. Next will be larger diameter ring. So if you use an unnecessary large diameter ring, then that also leads to less tension in the wires. So how to tension? We have 3 methods, that is dynamometric wire tensioner, Ilizarov's manual machine to be used, or a Russian manual method. So among this, the best will be the dynamometric wire tensioner. Why? Because it is accurate and it can be reciprocated by any surgeon. So you don't want any surgical skills. But whereas the Ilizarov wire tensioner and Russian manual method, it is technically demanding and you should be trained in that. The manual tensioning method can be used only in emergency situations where you don't have a dynamometric wire tensioner. So try to do not perform Russian method unless you are very well trained. So a stiffness of a tensioned wire is equal to that of a shank spin. So here you can see an example. The tension of the wire is directly proportional to the stability of the construct. Here in the green arrow mark, you can see a tensioned wire using a dynamometric wire tensioner. The wire is straight. Whereas in this case, the surgeon has used a Russian method where you can see the slackness of the Ilizarov wire. So due to this, what happens? There will be a loss of stability and you will not be able to achieve a successful outcome. So how much tension to be applied? In a full ring, you can apply up to 130. So here you can see the dynamometric wire tensioner where there will be graduated markings 90, 110, 130. So depending upon the ring and the wire used or the quality of the bone, you apply the tension. So for a full ring, it will be 130. For a full ring on washers and lengthening cases, you apply up to 110. And on drop wires and half rings and 5/8 rings, you apply tension up to 70 to 90. And pediatric bones, you apply less tension to 70 to 90. So now coming on to the shank spin. The shank spin, there are 3 different common types. That is normal shank spin, which is the thread diameter will be the same entirely. This is commonly used mostly in AO external fixators. And the latest ones are shank spin with self-drilling and self-tapping. The problem with this, it is less time consuming, but it can damage the opposite side neurovascular structures, which is not ideally used for a Ilizarov fixator where you use the fixator for longer duration. So the best one will be the shank spin, which is tapered. So here you can see a differential thread pitch, that it starts in the tip at 5 mm and ends by 6 mm. So ideal sizes for pediatric and forearm will be a 4 mm shank spin. For tibia and humerus, you can use a 5 mm shank spin, and femur and tibia use a 6 mm shank spin. There are 3 different materials. You can use a stainless steel or titanium or hydroxyapatite coated. The stainless steel, it is cheap. It provides a good strength. The titanium comparatively has a better tolerance for the soft tissues and bones than stainless steel. Hydroxyapatite has a good bone pin integration. If you are going to use the fixator for more than a year, and if the bones are very osteoporotic and patient is affordable, then you can go for hydroxyapatite coated pins because there is less chance of loosening. So here you can see the best shank spin to be used for Ilizarov fixator will be a 6 mm tapered thread. Advantage will be you have a different geometric increase, that is from 5 mm to 6 mm, so it is more stable. If the shank spin gets loose, then you can turn it clockwise so that it gets little more tightened. But the disadvantage will be you have to use a C-arm check whether you have got a bicortical purchase. If you overturn the threads, then if you try to loosen it, the shank spin on the day one itself, it will become loose. So hollow wires, they are mainly a metallic wire in the metallic bead in the wire. So they are manufactured by milling technique. It is commonly used for interfragmentary compression in fractures, or it's used in osteoporotic bones where the normal smooth wires might migrate. It increases the stability of the construct when you use hollow wire, and it is used for fracture reduction, for angulation and translation corrections of the fragment. So what is a drop wire? A supplementary wire which is significantly increases the bending and torsional stiffness of the construct. Here you can see where you are normally in each fragment you have to apply at least 2 rings, Where you are not able to apply 2 rings, you are able to apply only 1 ring. You add a additional drop wire to increase the stability of the construct. So here you can see in the proximal tibia where there is a deformity, we added a drop wire additionally to provide more stability to the construct. So now next common question for beginners will be how many pins and wires should be in each fragment or ring. So minimum will be to use at least 2 Ilizarov wires and a half pin, or 3 tensioned Ilizarov wires can be applied, or 2 wires and a drop wire. So ideally my thing will be to use 2 wires and 2 shunt spin. Always 1 wire or 1 shunt spin more will be better on day 1, because later stage if there is some pin tract infection or the patient has pain, you can have the chance of removing 1 wire at shunt spin. So more the number of pins and wires, more the stability will be present. So what is the crossing angle of the wires? This is very important. So the right side image, you can see the black and white image. The ideal angle will be 90 degrees of the wire, so that the bone is very stable. In the B image, you can see 2 parallel wires which are passed. Still there is some motion which can happen in the mediolateral plane. If the crossing angle of the wire is less than 30 degrees, you can see in the image C and D, still there is some micro motion happening. So the ideal crossing angle will be minimum 45 to 60 degrees will be an ideal angle. So what you can do if you are using only 30-degree crossing angle, then you can add an additional shunt spin to that. So where to place the wires in case of deformity correction? So the concept will be, here you can see how do you correct a deformity, like how you apply a cast. So similarly, you can see here the position of the thumb, we apply 2 olive wires to increase to help in correction of the deformity, acting as a hinge, and the place of the index finger you apply 2 olive wires or 2 shunt spin to provide this opening out and easy deformity correction. So this is applied by the using the rule of thumb. So now giving just an overview, what are the how to apply a proper wire fixation, proper insertion technique, low heat technique, proper wire tensioner should be used, trying to secure the wire directly to the ring, increasing the crossing angle, try to achieve at least 45 to 60 degrees, use appropriate olive wires and drop wires. Most important will be thorough knowledge of the cross-section anatomy of the extremity. While passing near the joint, try to place the joint in an end range of motion. So why do you use Ilizarov wires? What is the difference compared to an LRS, that is shunt spin? The wires allow axial micromotion. That is, it produces a trampoline effect. So on weight bearing, it encourages osteogenesis. The Ilizarov wires are mostly used in case as a reference wire to mount the frame. In small bone fragments or pediatric fractures also, we can use Ilizarov wires. So now coming on to the ring material, there are 3 different. There is stainless steel, aluminum and carbon. The stainless steel, their advantage will be providing good strength and durability. The disadvantage, it is radio opaque and heavy weight compared to the other 2 materials. So radio opaque, here you can see in this image the X-ray. This is a fracture in the distal tibia, where when used metal ring, stainless steel ring, we are not able to appreciate whether the fracture is united, whether the joint is, how is the joint. So these are the disadvantages of stainless steel ring. In these situations, you can use an aluminum ring, which is radiolucent and less weight, or you can use a carbon ring, which is also radiolucent and less weight, but some reported chances of implant breakage are there with the carbon rings. So what will be the ideal ring size? The ring size is selected at least provided in the femur 3 finger breadth posteriorly and 2 finger breadth in the tibia and humerus. This posterior, there will be commonly swelling and dependent edema. So hence we are giving a good clearance posteriorly. So here you can see the ring of mounted over a leg, where the leg is completely in air and the ring is provided with complete stability. So suppose if you think and you add more, if you add unwantedly, if you increase the size, suppose if 160 mm ring is enough and you add a 180 or 200 mm ring to a particular site, it reduces the axial stiffness, the bending and torsional load, thereby reducing the stability of the construct. So ideal size of Ilizarov rings to be used. Sometimes when there is impingement, then you can use something like this as a cardboard back of the thigh. So there is a formula to calculate the ring size. So you calculate the maximum circumference of the calf. For example, it is 33 centimeter, then divided by 3, that is 11 centimeter plus 5 centimeter is equal to 16 centimeter. So the ideal ring to be used for that patient will be 160 mm Ilizarov ring. So how many rings in each fragment? Ideal will be to go for 2 rings in each fragment. If the fragment is very small, then try to add more drop wires or shunt spin can be added. So the location of the ring, we depend upon the near, far concept, like how we have for a plate and nail. So here also, the near rings, the second and third ring will be at least minimum 2 to 3 finger breadth, that is 4 to 5 centimeter away. Because in later stage, while docking, it might create more problems if you put the ring very close to the pathology. So try to be at least 2 to 3 finger breadth away from the pathological side. And the first and fourth ring will be far away, providing a good span and having a good working length. So the more the number of rods, the more the stability of the frame. So normally, ideally, at least will be to use 4 rods between 2 rings when the side. So here in this case, I wanted more stability. I have used around 6 connecting rods for additional stability. So the connecting rods, if it is more longer, then it creates instability. So here you can see when the lengthening is more than 20 centimeter between the rings, you try to use a dummy ring in between. This is a case of lengthening over nail where you have used a dummy ring in the middle segment so that the rod doesn't bend. And or you can use a telescopic rod also in lengthening cases too, so that the rod doesn't bend. So the key note for this present will be try to use a required size of correct ring and 2 ring block in each fragment, at least 45 to 60 degrees of crossing angle. Ideal tension will be around 110 to 130. So the intrinsic factors will be to provide a good bone contact. So here you can see a transverse fracture or oblique fracture, which is converted into an interlocking pattern to provide a good stability. So as much as possible, no gap between the bones, no deformity to be present, and viability of the surrounding soft tissue is paramount importance. So the comparison between the Ilizarov and uniplanar fixator will be, it is working on I-beam concept. There will be a trampoline effect so that it provides more 360-degree stability in Ilizarov, whereas uniplanar fixators work only on cantilever mechanism. There is less transfixation through the soft tissue and less bulk of the frame in uniplanar, but all the other stability factors are more stable in a Ilizarov fixator. So here there are many studies which support that use of an Ilizarov wire wherever required is always better than using a shank spin. So as per my teacher's talk, Professor Vasudevan sir tells, try to use the Ilizarov wires more in the metaphyseal and epiphyseal area and try to use the shank spin in the diaphyseal area where there is soft tissue so that the transfixion of soft tissue doesn't happen. So the Ilizarov wires with tension wires leads to an uniform compression, which enhances healing and prevents complications like malunion, deformity correction, and non-union. So I'd like to complete my quote with the words of Professor Ilizarov by himself. The results obtained with the author's methods have naturally attracted the interest of many surgeons. What seems at first a simple procedure can lead into the catastrophic outcome if the fixator is applied with insufficient knowledge of basic principles and techniques of application. I thank one and all for giving me this opportunity.
Thanks, Dr. Subramanya, for a wonderful, very descriptive, elaborative talk. I hope youngsters will be learning a lot from this talk. So, for him now, I'll request everybody if anybody has any questions. Manish, sir, your expert comments.
Yeah, actually, I'm on the road. I see. He has covered almost everything about biomechanics. Mother, I don't find, but only one comment that Subramanya has told that you should not use wires in the tibia. Am I audible?
Yes,
Can you hear me?
Yeah.
Yes.
So you had told that, try to use more of wires in the metaphyses and
Not audible, sir.
Sorry, not audible.
Yes, sir. We can hear, sir. We can hear you, sir.
Hello? You can hear me now?
Yes,
Yes.
sir.
Am I audible?
Yes,
sir.
very
Yes,
well.
sir.
So you had given a comment that, more wires should be used in metaphyses and less wires should be
Sir, I
used
want
in
to
the
tell-
diaphyses.
Yes, sir. Hybrid fixation in diaphyses and try to go for pure wire fixation in the metaphyseal and epiphyseal area, sir. That is, use wire and shank spin in the diaphyseal area.
No, see, that is okay, but you have to use, a mix of judicious. You don't make it a principle because you are claiming biomechanics. Now your message goes to all youngsters. See, you are in a way right, but there should not be a generalized rule, because the Shan's men also have their own problems. Okay. And because it increases the stiffness, and so you have to decide on the situation and do accordingly. So if muscle bulk is more, okay, avoid this thing. And usually if you use pins on one side, so try to put wires on the other side, means at the other end, because it maintains the flexibility of the frame. So it is not a generalized rule, yeah, but okay.
Yeah, Manish.
Yeah.
Vasu sir, good evening, sir.
Yeah, what he is talking about is the proximal tibia. It's compared to diaphysis, it's a weak bone. So it is better to go for isoelastic fixation. Isoelastic means wires are more flexible. That is why even in old age patients, in osteoporotic patients, it stays longer. Because the wires are equally stabilizable to that metabolism area. Whereas in the diaphysis, pins are much more strong and more lasting.
Agreed.
That is the point he is raising.
No, I agree to this point. There is no controversy about what I was telling him, because you have to, if you say, then it goes as a rule to the listeners, So you can tell, but yes, there has to be mix up of things. Only thing is that we cannot make as Professor Vasudevan has told, we do not make it totally stiff. Okay, so he's telling at the proximal tibia, you have to have wires for flexibility. You can use pin at the other side. So it is a mixed of thing depending on the biomechanics. So okay.
Yeah, and if one side you have only wires, then you have the benefit of wires from one side, your stability from the other side.
Yes, that is it.
Yeah.
Otherwise, I think you have covered everything, and very elaborate. And I have heard this lecture previously also, your lecture.
Yes, sir.
I think it's nicely done, and you have put a lot of hard work, and you have covered almost everything.
Thank you, sir.
Thank you, sir.
Yeah,
Thanks,
well done, Gandhi.
Yes, sir.
Thank you, sir. Thank you so much,
Very
sir.
nostalgic. So I can see we have Bari sir here, Dr. Amar Soni. They want to give any feedback. Also, thanks for coming, sir. So, any more questions for Dr. Subramanyam?
Sir, I have one question, sir.
Please.
So, what is the ideal wires? How many wires you can use it in single ring, sir? Because I have used in distal tibia. Most of the time, if I use more than 2 wires, like 3 wires during tension, so first 2 wires tension is okay. When I do the third wire tensioning, the first or second wire tension is getting loosened. So what I am doing some mistake? I want to.
See, can I answer this, Subramanya?
Yes, sir. Please, sir. Please.
See, you have not specified that whether it is a full ring or it's a 5/8 ring.
It is a full ring, sir.
Full ring usually it does not happen. I will ask, but 5/8 ring, yes, because if you tension a wire, and then do another one, tension more, then it get loose. So, what is your comment, Subramanya Gandhi?
Sir, one more thing which I missed in the talk. Correctly, Dr. Manoharan sir has brought up the point, very, very important point, that when you use a dynamometric wire tensioner, try to use, if it is going to be a full ring, try to use the same tension in the wire that is applied in that ring. That is, if you are going to apply 110 to a particular wire, try to use 110 to the other wires in the same ring. If you apply one wire 130, the same wire, suppose if it's a male post, if it's applied on a drop wire, that is different. But if the wire goes through the ring, then try to apply mostly same tension in all the wires. What can be the problem is, one wire you could have applied 130, the last wire you could have applied 90 or 110, sir. So what might be there? The loading might be more in the 130 applied wire. So, and one more thing, that commonly the wrapping effect of the ring might be there. So try to apply one wire above, and to counter it, try to apply one wire below the ring. That is in the same level. So if you apply all the wires in the above level itself, commonly what happens, there will be too much of bending like this. So try to apply one wire above and one wire below if possible, so that the ring is maintained straight, so that it doesn't have the wrapping effect.
Agreed.
Thank you.
Do you have
Yeah.
titanium shaft pins? I think we have got only the stainless steel tapered pins are available. Then HA coated is available. You are talking about titanium, and is the titanium pins are available in the market?
Yes, sir. Many people are using, I think, sir. Many people are using,
Company
like, not
does.
available for us in Tamil Nadu, sir.
Okay.
Mostly they're
Which
using
company?
not Amarsoni,
Because
sir.
the titanium will
Millions.
be lightweight, and integration to the bone will also be good. But it is not available. Definitely, it is not available in Tamil
Sir,
Nadu, to my knowledge.
sir,
It's available, sir.
It's
Where?
available with Pittsburgh also, and some local manufacturer are also producing it. I am getting it from Baroda.
Okay.
But Pittsburgh
Practically, is there any added
Pittsburgh is
available?
giving all sizes in all diameter and all thread lengths.
Yeah. And long threaded pins are not, tapered pins are not available with Pitker. For example, they manufacture up to 200 mm length alone. But fatty people whose femur has to be lengthened, we need at least 240 or 250 mm pins.
Yes.
Are they available?
I have got
Available with
such
Uma
10
surgical,
pins
sir.
in my stock made specially for such cases.
Okay.
I keep such 10 half pins in stock.
Okay. Okay.
Yes.
Dr. Amar, do you see any added mechanical benefit while using titanium pins or wires?
Sir, I am using since years titanium pin only since the days of fellowship, and I am very comfortable with it. And overall pin track issues I am facing very less as far as half pin is concerned.
That's true.
Necessary, sir. Any comments, sir?
Yeah, good evening, everybody. I was in China, so there they never use 1.8 wires. All 2.5 like thick wires they use, and they have very good, very nice regenerate, nice union. So it is all the diameter of the wires and diameter of the shank pin, where to use in the metaphysis, what to use. It is all subjective, and but when we teach juniors, we should teach ideal things. So there are so many other things. And regarding titanium shank pin, so I have been using since 5-6 years. So the purchase of the shank pin in the bone is excellent, and very rarely pin tract infections and loosening. In very few cases, since I started using titanium shank pin, very few cases I had to replace it. And of course, the technique of insertion is same as we apply for the stainless steel. But I feel patient is also more comfortable with the titanium shank pin. And with so I get it from Delhi. A person is there by Deepak. He makes it with a very meager amount. So I have been using it in civil hospital also. So I feel so titanium shank pin, they give better results and more patient compliant.
Necessary.
Yes, sir.
Necessary. For the 2.5 mm wire and 2 mm wire, how much tension they use?
They don't do tensioning, sir.
So
they don't do tensioning. There is no tensioner in their set.
So what do? They just tighten it.
Yeah, just tighten it.
So that is the lengthening produces tensioning.
Yes. While yeah, even non-tensioning also, like just like a deformity correction, they don't do any tensioning, sir.
Okay.
So anybody going to China, you can just if you get a chance, you can visit Professor Chin's hospital and have a look. Really, it is worth watching there. There will be so many patients. He'll be operating around 13 to 15 cases per
No,
day.
that is essentially that is it. Now, when you're 1.8 mm, you must tension it.
Yeah.
The 2 mm or 2.5 mm, even without tension, you can escape.
Yes, sir.
Because the thicker the wire, you don't need to. That is why you don't tension the trans screws.
Yes, sir.
And when you go for more than like 6 mm, you don't need the other end.
Yeah. Yes.
So there is one question in the chat box, sir. Whether we have to go for a progressive frame or a pre-constructed frame, which is better?
Surgeon choice.
Vasudevan sir, can you like to enlighten us on that, sir?
It depends on the level of your experience. Beginners may need a pre-assembled frame. And one advantage, they are already pre-planned, because without pre-planning, you cannot make a pre-assembly. Whereas an experienced person like Gandhi or Govardhan sir can do even without any this thing. They can make it on the table. That is mainly because of experience. I don't make a pre-assembly nowadays.
That even I make pre-assembly, sir, because I don't have proper assistants with me. I have only postgraduates. So what I do in fracture cases, I make the rings and keep it like a jig. So I don't construct the entire frame. So like block, I make it ready. If in deformity correction cases, one day prior, I take the patient to the operation theatre, use a C-arm, mark the level, mount the frame on the limb, and check whether the hinges, everything is correct.
So you can finish the surgery.
Time.
You can finish the surgery quickly.
Easily.
Quickly. Yes, sir. So now we'll move on to the next speaker for today, sir. Welcome, Professor Suresh Gandhi, sir, from JIPMER. He is the professor and head of the Department of Orthopaedics, JIPMER, to enlighten us on today's topic. We welcome you, sir. You can share your screen, sir.
Yeah. Good evening, all. First, I would like to thank Asami India and Gandhi for giving a talk. And also, I'm happy to present with my teachers of Dr. Govardhan sir and Vasudevan sir, who is like inspired us to do a Ilizarov throughout our procedures. I will take 2 minutes before that my presentation. I'll share this screening. Dr. Manoharan asked about the rotation correction and the first Dr. Govardhan sir class. Actually, this is a patient having an internal rotation of the tibia. You can see here. And after the deformity correction, this is the construct. Actually, this was described, maybe I will discuss with the Vasudevan sir at that time. I made it a 3 construct like this. The both will be this one construct. This is the distal part. This is the proximal part. You can see this attached to the ring. And I did a fibula osteotomy. You can do a gradual rotation correction. What sir told me is, if you want to do an acute deformity correction, do the rotation first and do angulation correction. Then only you'll get a opening wedge and good contact. In acute correction, if you do rotation correction, after that, if you take a wedge, contact will be less. That is one thing. If you do a gradual correction, do the rotation at last. These are the things we learn. But problem I encountered this case is, I did a correction. You can see that after correction, you can the skin ranges also. You can see that rotation, I got it through the same instrument. But finally, I had a translation. So then I had a problem, like, I don't know, like what to do. And after that, I discussed with him, like, because of tibia is not center of the ring. That is the only thing. If you do it in the femur, it may work. If you do any rotation correction on the tibia, very careful, because tibia is not center of the ring, so that it will translate. If you want to do a rotation correction, better use any intramedullary device over that you can rotate, or once if you do a rotation correction, try to correct the translation acutely. Probably you can get the rotation correction. So this is the final correction of this patient. So that is the thing I want to show, that construct of Ilizarov, how we did corrections. So anything, sir, Govardhan sir want to tell about it? Maybe I'll proceed with my talk.
Yeah.
Yeah, I'll go with my talk. It's a simple single case presentation. It's a oblique plane deformity. It's not a deformity with stiff non-union. A simple case presentation. He is around 45-year-old male. He had a head injury, and the patient was, that condition was unconscious for 3 months. So we couldn't operate for him. Patient was in the plaster. After that, he went out and didn't take any treatment. And then we started walking with this. The patient, after 1 year, he came with the deformity of mid tibia. There is some skin changes also you can see. And also like you can see that all the views, this is the lateral view, this is the anterior view, and this oblique view. You can see the deformity in all the planes. And the X-ray shows, you can see there is a varus deformity on the AP view and the procurvatum deformity, and you can see the slope and other things. But still, radiologically, it's not united. Looks like a stiff non-union, and the fibulas looks like appear to be united. So, as first class, Dr. Govardhan sir told about that planning. The posterior proximal tibial angle is around 53 degree here, and also medial proximal tibial angle is a mechanical. Both mechanical is around 38 degree here. Then I used the Ilizarov because more than 50 degree deformity and doing acute correction is difficult. One more, and correction of this acute correction may be a lot of problem that you have to go with the shortening or blood loss, all these things. So we consider Ilizarov, and then we plan for the oblique plane deformity. Same as like you can see a ring planning. You can take a oblique plane deformity in the graph method. You can see the 55, and we take it as 1 mm to 1 degree. So here I took a 55 mm in anterior procurvatum and 51 degree of lateral angle. So that you can see the oblique plane deformity axis through this angle. From there, you can draw the tibia also. Tibia is maybe almost in the left leg and anterior view. Planning an oblique view always may be confusing where to keep anterior, posterior, medial, lateral. Always I used to see like if I wear a ring on left side, this is patient on left side. So if I wear my ring on left side, so I plan it, this is anterior, posterior, and medial for my ring. How I wear a trouser or something, same thing I wear this ring. So I had to plan. After that, I keep the hinge 90 degree to the axis, the original axis. You can see that angle passes through the apex of the tip of the tibia. So it's important because always in Ilizarov, we mostly will use it for open wedge correction, but acute close, if you want to do acute wedge correction, maybe you can use it, you can use the Ilizarov. Otherwise, if you have the hinge correction, most of the time we'll use the open correction, so that I'll keep it in the apex of the deformity. Then this is the ring assembly on the table. The same as the plan as previously, you can see that this is the center of the ring, anterior third and the posterior two third. And also like here he used as a osteotomy rule number 1, but here I didn't do the osteotomy because already there is a non-union there. I did only small incision and put a fibula osteotomy. You can see like this is the fibula osteotomy only I did. And I didn't touch anywhere in the bone, like because the skin condition also not good. And we started angular, slowly gradual correction. Usually, normally we used to wait for 3 to 4 days for latency period during osteotomy. Here, once the patient comfortable with the pain, and second, third day we started distracting. And you can see the distraction osteogenesis. Same thing, osteotomy rule number 1. You can see the open wedge. And how will you correct the calculate the distraction? You can see the rule of triangle. Two same isoelastic triangle. You can see that distraction of this percentage maybe if you calculate. If you want to do 1 mm here, I have to do here 2 to 3 mm. This maybe you can use the triangle calculation, and we gradually distracted. And finally, this is the final correction. Almost you can see the anatomical correction. This is the excess of callus. And finally, this is the correction. Before that, we did a trial walking. You can see all the rods removed in between the non-union and made the patient to walk for maybe I used to walk for 1 week. I told them to remove the rod and walk for the 1 week before removal. This is the 6 months follow-up. You can see if you draw the line, it's anatomical correction. Almost both knee and the ankle is parallel. And also, you can see the good solid union at the sign of non-union without doing osteotomy. This is the functional, this is the alignment. This is the functional of the patient. Maybe he is able to walk now. It is having milder problem of the pin site, small ring cecostum at the distal pin site. That will also manage later. And now he's walking independently with good aligned lower limb and is able to do his all activity at present. Yeah, thank you.
Recording in progress.
Thank you, sir. Like anything?
Sir, thank you. Thank you very much for the excellent talk, sir.
Yeah.
Sir, can you
Can you
stop your screen sharing, sir?
It was a good presentation of a difficult problem which Suresh has shown. It's very nice.
Thank you, sir.
Anybody has any doubts, sir?
There is a technique described by Dr. Takashi Matsushita from Japan, where he has suggested that you can do bone chipping in such a stiff hypertrophic non-union with deformity. And in such cases, he has done acute correction of such long-standing deformity also. I've done few cases and done fixation with even plate and femur. But these are time-tested method, and we all do. I've also done lot of cases of gradual correction with ELISA method. But just I'm mentioning another way of handling such cases. Just I've come through.
I also like want to do a internal picture. Like suppose if you do a correction less than 20 degrees,
Yes,
like minimal degree, like maybe acute correction is okay. More than 50 degree of correction, maybe we end up in shortening and other things. So,
yes, I agree, sir. I agree.
Suresh, sir, thank you so much for showcasing that rotational deformity correction, how to be corrected the rotational device, sir. It's always a most important question. Most of the topics, how to do rotational correction and translation correction using hinge method. Thank you for sharing that picture first of all. And thank you for excellent presentation for today, sir. So as there are not much questions, we'll move on to the next topic. So the next speaker will be Dr. Manoharan from Vellore. So he is a senior consultant at Naruvi Hospital, Vellore. So over to you, sir. You can please share your screen.
Yeah, I will share my screen. Is it my screen is visible? Am I audible?
Yes, sir. You're audible. You're visible, sir.
Thank you, sir. So once again, I would like to thank Asami India as well as Tamilnadu Pondicherry chapter for giving this wonderful opportunity to discuss one simple deformity cases for the young surgeons like me. So this is a case history. The 37-year-old male patient complaining of pain and deformity over the right leg since 2 years. He had a trauma 2 years back with a grade 3B open, both bone leg fracture, distal third. Underwent like a routine stage 1 procedure, debridement, external fixator. Then later on, converted with the Ilizarov and plastic surgery cover. It was all 3 procedures done in elsewhere. Then patient was not tolerating the frame, so they have removed the frame prematurely as well as plaster is applied. But patient was not listening to patient was not listening to the surgeon's advice, so he was walking with full weight bearing, so deformity, he ended up with deformities. So this is the clinical picture. The gross varus deformity with shortening of 3 centimeter with multiple puckered scoring around the apex of the deformity. So this is the X-ray picture showing the distal third varus non-union of both tibia as well as fibula. So in coronal plane, there is a deformity of 33 degrees, and sagittal plane, not much deformity was there. So this can be done either way, like acute correction as well as gradual correction. Considering the shortening, so doing acute correction and putting intramural implant will be we'll be leaving it with the shortening. So I chosen the option of gradual correction. These are the options which I had in my mind. So like everyone said, I also do the preoperative planning with graph method. And what in this case, what I was did is like I marked like a sketch marking in the leg itself before draping. So like use the C-arm and metal scale and use this scale to make this perpendicular to the. So these lines are indicating the level of the rings, which I already pre-assembled before autoclaving. So then I marked by using the Ilizarov rods and center of the axis, the anatomical axis of proximal fragment as a distal fragment, and Cora was found. So I marked everything in the sketches. And these are the basic things before assembly of the frame as well as, so these are the hinges and this is the motor you have to assemble with the frame. So in this case, since the deformity is distal third, so I use the ankle as a reference wire, first reference wire paused in the ankle, and pre-mounted frame will be, after putting the reference wire, tensioning done, then the second wire and third wire, second ring and third ring, I made sure that this is lined with my skin markings. Then the rods are parallel to the skin markings in the center of this. So that will make sure that my ring is positioned in the center of the leg. So otherwise, if you are not concentrating that, so maybe our ring will be not in the center, leg will not be in the center of the ring, and the skin soft tissue impingement will be there, and proper placement of the ring cannot be achieved. So this is the second ring. I make sure that it is perpendicular to the proximal fragment, and as the rule, so always you have to fix the reference wire first to the parallel to the joint, and second wire will be the distal most wire. That means in this case proximal most ring. Then sequence of fixations is followed. This is the final construct, and I align the C arm as well as this is the osteotomy Cora. So I align the hinges. So in the apex of the deformity, and since I required some more lengthening, so I kept the hinge little away from the Cora and in the same line in the bisector line. So since the poor skin is there, so anyway I have to do the osteotomy of the fibula. So through the same incision, I did a percutaneous osteotomy at the Cora level and confirmed in C-arm AP lateral. This is the final construct. So throughout the procedure, I didn't use a tourniquet. So in a Ilizarov, I think tourniquet should be avoided to immediately find out the neurovascular injuries, vascular injuries. So this is the way I did a thing. This is the immediate post-op X-ray. Then after 2 weeks of distraction based on the triangle method calculations, this is after 4 weeks of distraction. So once the deformity is almost fully corrected, so I exchange the hinge wire, hinge and motor to the straight rods, then allowed the patient to weight bearing and walking with as tolerated. So most of the time is a partial weight bearing, and since the patient is from Bangladesh, so I am not able to follow very closely. So after the patient was always following the partial weight bearing only, and patient came to me after 10 months of this surgery with, this is the final picture. So it was showing exuberant callus on the medial side, and there is no callus in the fibula as well as lateral cortex. It was still regenerated, good regenerate is there. So I did a trial rod disconnection like dynamization. Then I checked it, there is no pain in this patient, and patient is coming from the long distance. I cannot ask him to wait for another few more months in Vellore and try to delay the removal. So in this case, I checked. First, I asked him to walk with full weight bearing without removing the rods, just to loosen the distal rods like dynamization. He was able to walk independently without any pain. Then I totally removed the rods from this, and for the fear of breakage, so I asked him to walk with walker support. Then I did a removal. I make sure I have discussed with the patient saying that in this stage, either I can remove this ring and put the plaster for 3 to 6 months time, or else I have to put an intramural rod to protect this region rate and deformity correction. He was agreed to go for internal fixation. So right now this is the situation. Then after the pin tracks everything heals, I will be going with internal fixation after 2 weeks of time. So for just for the prophylactic stem protection. Thank you for listening, sir. I'll stop my sharing. Any questions, sir?
Thank you very much for excellent case presentation, sir, and showing us the thing which happened and how to counter it also. So it will be a great learning for everybody and budding Ilizarov surgeons also, how to go up with the complication also. So in most of your deformity correction cases, do you pre-plan the frame, sir?
Yeah, yes,
Reconstruct
always
frame?
I will reconstruct my ring, and minor adjustments I will be doing in the intraoperative.
So in this case, was calcaneum ring required, sir? Because it was a distal
Since
level.
the deformity is far away from the metaphases, I am able to get a good purchase and good fixation in the distal fragment. So I neglected the ankle. So ankle I purposely left to increase the ankle mobility to avoid the ankle stiffness.
Okay.
Dr. Suresh here.
Yes.
One thing, like you did osteotomy through the same approach of fibula, like that was
Yes.
like no, usually we know like anterior tibial vessel is like we don't know where it crosses from anterior to posterior, and that is one question. And second question, you did a lengthening also. Like lengthening means there will be a like in this patient I couldn't.
So very few centimeters because 33 degrees
See,
of
but
deformity.
lengthening it will shorten the TA indirectly, like contactless. So maybe the Euconnus maybe like for me like very difficult to handle. That is the most difficult problem to handle in Euconnus in correction. So any distal deformity, if we do lengthening now, recently I'm using all the cases. I use the foot frame, at least 4 foot frame to prevent Euconnus. This is the one thing I want to. Yeah.
Yes.
Okay, since I allowed the patient to do partial weight bearing, so ankle was almost in plantigrade position, not going for any equinus deformity. Sir.
Yeah, thank you.
Thank you.
So any further questions, sir? So if there is no any further questions, we'll move on to the last talk for today by Dr. Velmurugesan, sir. He's associate consultant in Ganga Hospital. So please, you can share your screen, sir.
Good evening, all. First, I would like to thank Asami India and Tamilnadu chapter and Suresh and Gandhi for giving me this opportunity. So I'll be presenting an interesting case of Janu Valgam. He was a 27-year-old gentleman. He was 220 kgs initially. So he was very motivated to reduce his weight. So he had undergone bariatric surgery and he has brought down his weight to 170 kgs. However, as he was exercising, he felt more pain on the lateral aspect of knee, more on the right side. So clinically, he had valgum on the valgus deformity of the knee on both the sides. However, right was symptomatic and it was more than the left. He was also hypothyroid. So this is his X-ray, which shows lateral joint space narrowing and osteophytes also on the lateral side. And the patella was not subluxated. And this is his walking video, both in the frontal and the sagittal views. So when we, as sir had already explained about the planning, first we have to draw the mechanical axis of the entire limb. So we find that the mechanical axis deviation is towards the lateral aspect, which indicates that the entire lower limb is in valgus deformity. And similarly, there is also valgus on the left side. Right? However, the right side is more than the left, and it is also symptomatic. So then we draw the individual mechanical axis of the femur and the tibia to identify where is the deformity. So when we draw we also join the joint orientation lines to measure the joint orientation angles. We find that the mechanical lateral distal femoral angle was 76 degree, which is about 12 degrees less than the normal reference value, and also the medial proximal tibial angle, which was about 104 degrees, which is about 14 degrees more than the normal medial proximal tibial angle. And we also measured the sagittal joint orientation angles. However, those both in the femur and tibia, they were found to be normal on both the sides. So there was no sagittal plane deformity, and it was purely a frontal plane deformity. But when we look at the deformity, now we have to identify which bone is deformed. So when we look at it, we find that both the proximal femur and distal femur and the proximal tibia has the deformity. So there was a 12 degree of valgus deformity in the distal femur and 14 degree of valgus deformity in the proximal tibia. So the total frontal plane deformity was 26 degrees of valgus. So we planned because he was very obese. it was very difficult difficult, and also it is very difficult for the patient to have a frame on the thigh. Right, so we plan to do an acute correction in the distal femur, and first for any deformity correction, first we have to identify the apex of the deformity. Here the apex of the deformity was at the joint, and the magnitude of the deformity was 12 degrees, and we have done an osteotomy of closing wedge, oblique plane, closing wedge, biplanar osteotomy, where initially KYs were used as a guide. Right, from the preoperative planning, we know that the wedge of the triangle, wedge of the base of the wedge must be 1.3 centimeters. Yes, and we have taken a horizontal cut and the posterior 2/3 with the base of 1.3 centimeters, and taken the cut from the anterior 1/3 posterior 2/3 junction and to the anterior cortex obliquely. So this and then we have completed the fixation after correcting with the entomofix. Next, then we planned for because the deformity was more than 15 degrees is, and we have planned for a gradual correction in the tibia, where we have used an Ilizarov. And the initial hinge was the cora was identified, and the hinge was placed at the level of the cora, and the osteotomy was also done at the level of the cora. So there will be a pure open wedge opening of the wedge with which is the osteotomy rule number 1. And this was as he was very obese, and it was very difficult to take immediate post-operative X-ray. And this was at 1 month post-op, where 1 month post-op, where we have corrected the deformity, and we have achieved our aim was to get the mechanical axis is to the center of the knee. That is not to shift it too medially also, because his BMI was more, or even the medial loading can again result in a medial side osteoarthritis. Yes, and this was at 1 month post-op up, and this is at 4 months post-op up, and this is at 6 months, and at final follow-up where at the time of ring removal. And this is the video which he had sent me from home. So he walks now without pain, and he has started exercising again to reduce his weight. So by this, I want to conclude that any deformity, we must do a systematic assessment to identify the deformed bone, and also we have to plan and correctly execute our plan. And here we have done an acute correction in a distal femur. Biplanar osteotomy helps us it provides more stability, controls the prevents rotational deformity, and also helps in unites faster. And here we have done a gradual correction of tibia to get the mechanical access, so that I can get the mechanical access to the center exactly, and also prevent sudden stretching of the common peroneal nerve. Thank you. So I'll stop sharing my screen.
Sir, excellent case presentation, sir, with showing a double level deformity and showing the importance of even a minor deformity of 10 to 12 degree in the femur, it has to be corrected, so we can prevent the obliquity of the joint.
Yeah.
Any questions from the audience, sir?
Good presentation, Velmurugesan. Actually, for me, it's very difficult to do a precise osteotomy in the distal femur. So you did anterior and two-third, and like for us, it's very difficult to get it. Normally, I use the nail, most of them supracondylar nail, and I try to correct the deformity. And used to do oblique osteotomy. That will give us stability. You will get a larger faculty for locking from the lateral side. And also to work as the osteotomy, oblique osteotomy comes to the floor, that edge should come to the cora. That will serve all the purpose and give us stability, internal stability.
Yes,
but your osteotomy, as you said, like two-third and all these things, it's very good. Very precise. For me, it's very difficult to do the precise cut on that. And also, like, use the plate for that huge patient, like, it's a small plate and good results. It's very good to see. Thank you.
Thank you.
Without any further questions,
we'll close the meeting.
Yes. Shamsul sir, the closing remarks.
So, hi, so we are finished.
Yeah.
Okay. So, can we conclude, Subramanian?
Yes, sir. You can conclude, sir.
So, I really thank all of the members of Asami India, and special thanks to our coordinator, state coordinator, Dr. Subramanya Gandhi, and Govardhan sir for giving a very good academic lectures and discussions for the Tamilnadu and the community chapter.
Thank
So,
you.
with this, yes, sir, thanks for the blessings, and we wish to see you all next month with the Rajasthan chapter, and then we'll be having Karnataka chapter and then UP chapter. And lastly, we'd like to request Govardhan sir for last few words before we end, sir.
No, it was nice that we were given an opportunity to show our cases in the Asami India platform. I should thank Ortho TV for providing us the webcast. And thank you very much. And all the three cases which were shown were extraordinary well. And Dr. Subramanya Gandhi has really did a very good job of presenting the basic principles and biomechanical principles of Ilizarov, which was exhaustive, but it was covering entirety. I think we had a good meeting during this 2-hour session with Asami India's help. Thank you.
Thanks for the blessing, sir. Subramaniam, one word from your side before we end.
First of all, thank Professor Govardhan sir for accepting. And it is a vast topic which sir has covered, showing from basic to expert level cases. And it has been simplified for even the PG students also, the presentation which sir has done. Main aim was to cover the postgraduates and more young budding orthopedic surgeons, which has been definitely achieved by today's talk, I feel. And moving on to the other three speakers, Dr. Velmurugesan sir, Dr. Suresh Gandhi sir, and Dr. Manoharan sir, with case presentations pertaining to the deformity correction and covering each and every topic of different case presentation level. So uniplanar deformity, oblique plane deformity, and double level deformity correction. So thanks to Asami India and the organizing team, Dr. Shamsul Hoda sir, Dr. Rajat Agrawal sir, for giving us this opportunity. And we'll all try to meet in person in Asami India next year.
Thank you, Subramaniam. Thanks a lot for the golden word. With this, thanks everybody for today's session. And stay tuned. Good night to everybody. Good night, sir.
Good night. Good night.
Thank you.
Mashi, we can end. Mashi, are you there?
Good night, everyone.
Hello, sir. Can I end?
Yeah, please end. Thank you.
Okay.